I've given a lot of online talks for a lot of different things, but never because I absolutely had to because of a shutdown like this. I hope that this is something that is useful for you guys. As I just said to Jeremy, for those of you who weren't on the first minute or so, I've actually literally never given a talk where every single paper that was cited was from the last 3 months. So it was pretty interesting for me to go through that and to think about what we know. I think the really, really critical message here is that we just don't know very much. A lot of the papers that I'm going to show you, or a lot of the things I'm going to show you, are actually preprints, which means that they're things that have been composed by authors, case reports, opinion pieces, etc., that are not peer reviewed. And that doesn't mean they're not good, but it does mean that, you know, some of it I think is really preliminary, and some things I think are impressions. I think the main point of today's talk is to bring up questions and have us think about what we should be considering, and then what answers we need to get, both by paying close attention to the patients that we see, as well as thinking about research approaches. So I also really, it's critical for me to acknowledge that this talk is very, very much based on the collaborative work of several of the residents, and I hope a couple of you guys are on today, particularly Adil, Lindsay, and Tova, who took it upon themselves to write a review article on neurological kind of concerns and manifestations and questions related to COVID. And that was greatly helped by Shelley Farhadian, who's an ID physician, as well as a neurology faculty member. So she's joint between ID and neurology, who I'll talk about later is very involved in the COVID response. And also Dina Kuruvira, who you guys know is a headache physician. She and Adil came up with the idea of writing this review, and so really contributed greatly to this. So in terms of the outline of what I'm going to talk to you guys about, let's see if I can forward. I'm going to talk about the epidemiology of the COVID-19 outbreak, just to give you guys, make sure everybody's on the same page. I think pretty much everybody has been glued to the news every day and knows what's been going on and knows when it all started, but it is kind of interesting to trace it, in particular in comparison to SARS, which is a similar virus, and I think we've heard a lot about the comparisons there. I'm going to talk about the actual virus and the structure of the virus and the pathogenesis of the virus in terms of causing disease. And this is relevant in terms of thinking about how this can affect the nervous system. I'm going to talk a little bit about just overall clinical manifestations of systemic COVID and what happens to patients when they get it. And then I'm going to spend a lot of time going through the really, really sparse number of neurologic reports that have come out so far in the era of COVID. And again, highlighting these reports mostly as things to bring up questions and things we should be observing. And we can talk at the end about sort of what the limitations are of those reports. But several of those, again, are preprints, they're not peer reviewed. Even the case reports that are published, I think, are fairly limited in terms of interpretation. But it is interesting, and the other thing, and Dr. Moeller can attest, a lot of the other services have already been looking at these reviews and I think thinking a lot about them in terms of the patients that they're seeing who have COVID. So I think it's important for us to know exactly what they show. And I'm going to end by talking about some of the efforts at Yale that are specifically around neuro-COVID, if we can make up that term. And this is just a really nice image from NIAID, which is a cell that has virus particles emanating out of it. So the cell is the kind of reddish purple thing, and the blue are all SARS-CoV-2 virus particles. So the first thing I'm going to mention is the epidemiology of the outbreak. And there have been some really, really terrific reports, very, very detailed, that have come out of China. So as everybody knows, the outbreak started in Wuhan, China. And this is a paper that's written, first author is the director of the Chinese equivalent of the Center for Disease Control, the CDC in China. And this is a paper that really describes the outbreak and the timing of it and sort of what happened both in terms of the first cases as well as the public health response in China. And I think the main point here is that the very first case, in retrospect, the blue shows the onset of symptoms, yellow shows timing of actual diagnosis. That reflects the fact that the actual diagnosis is based, in this case, on testing for the virus, which is in this slide is called 2019 nCoV for novel coronavirus, but which we now call SARS-CoV-2. And basically the yellow shows when the testing was available and people were tested, but the blue shows when people were actually first manifesting the condition. So you can see the first case was on December 8th. By December 26th, a physician noticed that there were some unusual cases of pneumonia, was reported to the local CDC, more of those cases were found. This is over a period of just a few days. And very, very quickly, after 4 days after that first report, they started looking for case finding, identified cases. By January 1st, they recognized that these cases were emanating from the seafood market in Wuhan, and so that was closed. And incredibly fast, within 1 week, the virus was identified, and sequences started being generated and shared with the scientific community, and a test kit was developed. So this is pretty remarkable because I don't think there's ever in the history of any epidemic been such a rapid identification of a pathogen and testing developed. By January 23rd, the city was completely shut down. By the 24th, another 15 cities were shut down. And that's really when all of these efforts started to, originally in China, came to kind of close things down to try to contain the virus. And the WHO was notified way back in December and declared in January that there was a international concern. So this is another timeline, and I just wanted to point out here that on the left is a timeline for the SARS outbreak. And as I'm going to show you guys in a second, SARS is a virus, another coronavirus with a very similar structure to what we have now for COVID-19. And this was a totally different disease, however. The first case was identified in November. Later in February, it was first reported to the WHO, so much, much more slowly. The virus wasn't actually identified, and the pathogen wasn't identified until April. There were a total of about 8,000 cases worldwide and 780 or so deaths of the SARS epidemic. So it was there were a higher proportion of deaths with that than with COVID-19, but a much, much smaller number of cases, probably mostly because it's much, much less infectious. COVID-19 outbreak, I went with you on the last slide about how quickly the response came out. This paper was published in February, and the current status then was that there were 1,000 confirmed cases and 8 deaths outside of China. And sadly, where we are as of yesterday is 1.8 million cases that have been diagnosed based on testing worldwide. So this has been a super, super rapid dissemination worldwide, and why we're so highly affected here in New Haven. Probably a lot of you guys are familiar with this really terrific resource, the Johns Hopkins University Coronavirus Resource Center. This is an amazing web page that has all sorts of data that you can access about, and it's updated in real time. So I downloaded these stats yesterday in the afternoon, and they're probably significantly different already today. As you can see here in the middle is basically this map that shows the outbreak, and the size of the circles are the numbers of people affected in each of these different regions. Total confirmed at the top was what was, again, as of yesterday. As you guys know, the US has the most cases by far that have been diagnosed. I'll say that the confirmed cases for all of this has the total caveat is that you have to be testing. And we have areas of our country where we've done a lot of testing, a lot of where we haven't done a lot of testing. So these numbers are just the best that we can get at. The total deaths at the top right are worldwide 113,000, and in the US as of yesterday, almost 22,000. These are really super nice graphs that you can generate using the same resource center. And what I did is I just, this is some of the top 10 countries in terms of prevalence so far. And you can see the graph in China starting on February 2nd, the levels were high in terms of cumulative cases, but very much were leveling off, probably due to their really, really intense containment strategies and case finding, et cetera. Versus in the US, where you basically can see that we've really had a huge takeoff of cases with a super high slope, much, much higher than any other country worldwide, as we just saw on the last slide. Importantly, this next slide shows the cases per 100,000 people. So although our absolute numbers are much higher than any other country. The US is sort of in the middle of these top 10 countries in terms of prevalence per population. And this next slide shows the total deaths by date. So again, the US has had a very, very rapid uptick, although there is, I think, flattening. We can look at that in the news and look at that more carefully. But this is the overall systemic disease and course of the illness, and I just wanted to show you guys to put this in context of why we should be worrying about it in terms of our neurologic patients. And then I wanted to tell you guys a little bit about the pathogenesis of the virus, and I think this is important not only for us to just understand how the disease is affecting people generally, but also to think about what those implications might be for understanding what it's doing in the nervous system. So first of all, again, this beautiful blue picture of these viruses, you can see that there's a sort of ruffled looking edge of these viruses. So the next picture shows a schematic. This is, I think, a 3D printing, actually, of a molecular structure that's been identified by electron microscopy of the virus. So basically, the surface of the virus is the blue, and then these spikes on the surface are the spike proteins that interact with surface receptors on the host cells or on the human cells or whatever mammalian cells that they're infecting, and allow basically the connection between these spike proteins and receptors on the surface of cells allow the virus to then bind to and enter the cell. So the spike proteins in this particular coronavirus bind to angiotensin converting enzyme 2 receptors or ACE2 receptors, which is super interesting, on human cells, and are able to enter the cell based on that mechanism. So of course what that means is that the location of cells that have angiotensin 2 receptor on them throughout the body determines which cells the virus can enter, or the tropism of the virus. So if they are only on cells in the airway, for example, they would only be infecting the airway. But the interesting thing is that, of course, we do have these receptors in other parts of our body. So this is just another reconstruction of the spike protein based on EM. The genetic structure is important to think about because, first of all, again, I do a lot of work on viruses. I mostly work on HIV, as probably some of you guys know. This is another RNA virus. This is a single-stranded positive sense RNA genome. It's pretty simple. It only codes for 10 genes. Those genes have encode for 26 proteins because some of those proteins are then spliced. And some of the proteins include things that allow the virus to cleave themselves, copy the genome, and then create the structure of the protein. So essentially, all of these genes allow the virus to enter into a host cell, replicate by using the host cell machinery, and then reassemble itself to use that machinery to essentially propagate way more virus and exit the cell and infect other cells. And that's the way all viruses work. I think the important thing here is I wanted to show you guys that there are a number of different types of coronaviruses. So COV stands for coronavirus. And there are a lot of similarities between SARS-CoV-2, which is the virus that causes COVID-19, to other known coronaviruses. The two on the left are animal-only hosts. So bats and pangolins are two hosts that have a lot of coronaviruses. There's an interesting talk that I give a reference to at the end that says that there's something like more than 1,000 different bat species, and they probably have coronaviruses constantly in equilibrium in those species that are constantly mutating and can make the jump to infecting humans. But SARS-CoV-2, the current coronavirus, is quite similar to the original SARS virus, SARS-CoV-1. So there's about 80% similarity in terms of nucleotide identity. And this is important in thinking about some of what we don't know yet about SARS-CoV-2, we might be able to understand by implication of what we already know about the original SARS virus. MERS, which is Middle East Respiratory Syndrome, also has some similarities to SARS-CoV-2. And so again, there are probably some things that we can extrapolate based on what we know about MERS. There are also a lot of coronaviruses that cause common colds, very common in children, but with less similarity. So again, I'm going to keep on talking, guys, but if you have questions, I can't see any kinds of things popping on my screen as I usually can in a Zoom call, so just interrupt. So I also wanted to show you guys a simple, kind of simplified diagram of what the virus actually looks like. This is from a really nice sort of info sheet, and I have a reference here that has a lot of information about the SARS-CoV-2 virus particle and about the disease itself. So this is basically just giving you some information about what the virus looks like. It's essentially a very simple structure. The outside of the virus has these spike proteins that are shown as trimers that interact with the ACE2 receptor. Inside the virus is the nucleic acid with nucleic proteins that allow the proteins to be sort of cleaved into different proteins once it's being transcribed. And I think a couple of important things is that very, very quickly, under this replication timescale, the virus can enter a cell very quickly after it's initially interacting with the cell. And then there's a pretty short eclipse period. So within less than a day and half a day, the virus can start creating and processing its own virions. And the burst size is the number of virions that are released from any given cell. And this is more than 1,000 virions per cell cycle yield. So a single cell can then release another 1,000 virions after a single cycle. So again, highly infectious, meaning we have a lot of virus particles circulating once we become infected. Now, I did think it was important to show this slide, which is a beautiful result of Lindsay McAlpine's work for the review article that we all wrote together. And this is basically showing what the literature suggests. These are potential sites that have ACE2 receptors. So I think that we don't know for sure that this means that these can all actually get infected by SARS-CoV-2. But they are certainly cells that have been shown in other types of studies or by other mechanisms to have ACE2 receptors on them. So number one is the nasopharynx, and I think that's important because it may have implications for some of the neurological questions and issues related to COVID-19. And then obviously the lung, which this is the main target of SARS in terms of, SARS-CoV-2 in terms of pathogenesis and clinical outcomes, the kidney, the enterocytes of the small intestine, endothelial cell, which may be important for a variety of cardiovascular and cerebrovascular conditions. And there definitely are there is some evidence that neurons and glial cells of the brain also can have ACE2 receptors, suggesting there's a possibility of infection by this virus. So thinking further, if we have H2 receptors in the epithelium of the nasopharynx and also potentially in the vascular endothelium, this provides two potential routes of spread of the virus into the nervous system. And we know that SARS-CoV-1 can spread into the nervous system along the olfactory nerves. So basically the olfactory nerves at the top of the nasopharynx can become infected by SARS-CoV-1, and then the virus can be carried through the cribriform plate into the central nervous system. So it's possible or hypothetical that the same thing could be happening with SARS-CoV-2. We also know that since endothelial cells have ACE2 receptors, it's possible that the virus can enter endothelial cells and infect those, and then potentially could cross the blood-brain barrier via the endothelial cell lining and enter the CNS. So either glial cells or other cells within the CNS compartment. Again, these are hypothetical, but I think they are possible, and they're partly based on what we know about SARS and MERS. So what are the clinical manifestations of this disease? Well, I think everyone knows that it's pneumonia and respiratory failure are the reasons that most people end up acutely and severely ill, and it's the cause of a significant amount of the mortality from this disease, culminating most severely in ARDS and then multi-organ system failure. We know that there are high concentrations of ACE2 receptor cells in the respiratory system. So in the pneumocytes, in the alveolar macrophages, in the mucus cells in the nasal cavity, there are many, many cells that potentially can get infected by this virus. And looking simply at concentrations of RNA, not necessarily a live infectious virus, but simply the virus from the RNA, these can be incredibly high in people who have SARS-CoV-2 infection or COVID-19. So you can see 10 to the 6, so 1 million to a trillion or something copies of virus per swab in the nasopharynx, for example. And interestingly, similar to acute HIV infection, which is what I know most about, actually the viral load in these different compartments is highest in the earliest, most acute phase of the infection. So unfortunately, the viral load is probably highest when people are first exposed and sometimes before they're actually symptomatic. This is a natural history of the infection in terms of an incubation period where people are probably not too symptomatic, and that probably lasts at least 5 days. Although, and 99% of them will have symptoms by 14 days unless they have an entirely asymptomatic course. So unfortunately, though, many of the symptoms probably come with a rise in immune response to the virus, which is again similar to what we see in other acute viral infections. So that for the period where people can have very, very high viral loads in, for example, in their nasopharynx or their nasal swab, they may not be symptomatic. And so this is one of the concerns and one of the reasons that we think there's been so much community spread is that people don't necessarily have symptoms while they're still infectious. So you guys know that there's a lot of different numbers that have shown up about case fatality rate or mortality in this condition, probably related to the prevalence of testing. So we just, anywhere between 0.8% and 10%, I think a lot of people feel that it's closer to 1 or 2%. Many, many people recover. Some people are completely asymptomatic. However, people who have severe cases can be intubated in the ICU for 3 weeks or more, and severe cases can go on for 6 weeks. And finally, I wanted to show this slide that just basically shows a natural history in terms of the sort of biphasic severity of the illness in many people. So this is for hospitalized patients. This is from a paper based on a large group of hospitalized patients in Wuhan, China, showing that people often are admitted after about 7 days after onset because they've started having respiratory symptoms that are severe enough for hospitalization. And then another 3 or 4 days after that can develop even further decompensation and an acute respiratory distress syndrome. Lab abnormalities, there are rife in this disorder, and I think there's a lot of interest in trying to understand what underlies those. Many people have lymphopenia, so drop of total white counts, neutrophils, platelets can drop, prothrombin time can go down, and D-dimers, creatinine kinase, troponin, C-reactive proteins, and IL-6 all can be elevated. And these inflammatory markers, I think, again, we can confer with our ID colleagues, but are actually predictive to some extent of how people are going to do with the disease. And I just wanted to point out, and I think this is important from a neurologic standpoint, during this period that people develop ARDS, it's often in the context of what we call cytokine storm. So they have really severe elevations in IL-6 and C-reactive protein, for example, and have a lot of systemic inflammation, suggesting that a lot of what's causing pathology at this point is not just the virus, but it's the host immune response to the virus. So as probably you guys know, although antivirals are being tried as treatments in COVID-19, there are also strategies that are using anti-IL-6 therapies, for example, tocilizumab and others, to try to combat the severe inflammation in this disease. Okay, so this is all the part that I think we have pretty good data on. There's a lot of clinical experience, unfortunately, worldwide on the systemic manifestations of COVID-19 and the severe respiratory failure and the morbidity and mortality. Now I'm going to venture into what I think is much more unknown and exploratory and talk to you guys about the neurological reports in COVID-19. And again, I want to credit the team of co-authors and the group that I mentioned at the beginning of the talk, who have really, I think this whole group that's been writing this review and then has been running this neuro-COVID consult service, which I'll mention at the end. Everybody's been super active in trolling the literature and trying to find new reports and seeing what's coming out on a day-to-day basis. And I'll tell you that things change every day. So this is the first paper that I think drew attention in the media to the fact that there may actually be neurologic manifestations in people with COVID-19. I would say from the very beginning, I think we have to think hard about whether or not these neurologic manifestations are specific in any way to this particular virus, or whether they are manifestations of um, severe disease in critically ill patients with a systemic viral syndrome and a lot of other complications. And I just don't think we know that, and that's how I'm going to start out addressing all of these. But this is a paper, and it was originally a preprint when we were looking at it, but it's now being accepted to JAMA Neurology, and so you can look at it, I think in the last couple of days it's been up, which looked at 214 people who were hospitalized in Wuhan, China, and looking over whether or not they had any neurologic manifestations. And I don't know if people can see me, but I'm putting that in quotes because I think, as we all know, as neurologists, many things that are interpreted as neurologic complications or manifestations are not necessarily truly emanating directly from the nervous system. This paper was written by neurologists, or at least neurologists were involved in the assessment of the patients. And so I don't mean to imply that they didn't know that they were neurologic or not, but I do think we have to take these things with a grain of salt. So CNS, they interpreted them as three different categories: CNS, peripheral nervous system, or skeletal muscle injury. And CNS involved the different symptoms or signs shown here. Peripheral nervous system, again, they interpreted taste and smell as being neurologic, and we're going to talk about that in a minute. Vision impairment and nerve pain, and then skeletal muscle injury, which I think is related to elevations in CK and also muscle pain. They found in the study that those with more severe infection had more neurologic manifestations. Overall, they found that 36% had what they considered neurologic manifestations. And interestingly, and I think importantly, and maybe one of the most important takeaway messages of this, is that there were some patients who came to the hospital only with neurologic manifestations rather than with shortness of breath or fever or cough as primary manifestations that turned out to have COVID-19. So I just wanted to show you the clinical characteristics in these patients, and the most important thing here of the 214, you can see in parentheses the percentages of what people presented with, and these are for the systemic presentations. 61% had fever, 50% had cough, anorexia, diarrhea, etc. So really most people had fever, but not all, and not all had cough either. This is a little bit of a busy slide, but I just wanted to show you guys, I want you to focus on column 1 here. So hopefully you can see my cursor, the people, this is the total. They then separate the manifestations into severe versus non-severe patients. That's based on their COVID systemic illness, how severe their disease was, whether they needed mechanical ventilation, ICU care, etc. But I think the most important thing simply is looking at the rates of some of these different conditions in the patients overall. So they thought that 25% of people had, quote, CNS symptoms, and only 9% had peripheral nervous system symptoms. And these individuals had dizziness and headache at pretty high rates, impaired consciousness in 7.5%. And then also they found strokes in about 3%. One of the main points of this is to show that they actually found more severe neurologic diseases in those with more severe clinical disease. So the other point here is to point out that this is looking at the delay in the time of onset of the neurologic symptoms compared to their hospitalization. And I think the important thing here is that, again, the number of days is shown with the range. And some of these presentations, some of these things were present as soon as patients were admitted to the hospital. So dizziness and headache, for example, ataxia and seizure were very early manifestations, and also impairment of taste and smell. However, impaired consciousness and stroke or cerebrovascular disease happened later. Does that mean that what we're seeing happening later is simply related to the cytokine storm that people get in that second wave? Or does that mean that there's actually a more indolent or maybe subacute presentation of CNS-specific processes that have to be watched for in these patients? But I think that that's maybe an important determination or distinction that some of these things brought people to the hospital who were there right away, and others occurred during hospitalization. So for the rest of these slides about the neurologic presentations, what I'm really going to do is show you a series of case reports. And as I mentioned earlier, some of these are not published, some of them are not peer-reviewed, they're all in the literature, so some of them are just presented as either submitted papers or as preprints. I think they bring up questions more than they provide any answers. I also think they're very limited. And I think this is important when it comes to other colleagues who can maybe look up these cases on the internet and know that they exist and make extrapolations for their patients. But I think we have to keep in mind that we really don't understand what these mean, and that a lot of case reports, there are many interpretations to what's going on. So for example, this is a case that is published from Japan that is being put forward as a case of meningoencephalitis in COVID-19. We do know that in SARS, there were reports of encephalitis, and many of those were corroborated by detection, for example, of the virus in the CSF, by a large amount of inflammation, MRI changes, and there has been the SARS-CoV-1 virus detected in autopsy in brains. So because that's true, I think there's some extrapolation to the possibility that could be happening in people with COVID-19. And this is a case of a previously healthy 24-year-old man who on day 0 developed headache and fatigue and fever. He went to his primary care doctor. He was tested for several things, but did not including COVID-19. Didn't have any positive tests on anything, continued to have fever and headache, and then on day 9 was found down at home unconscious. When he was brought to the hospital, he had overt neck stiffness. He did have ground glass opacities noted on his chest CT, and he also had multiple seizures. His MRI is shown on the right, and as you can see, there are hyperintensities in the temporal lobe. There is hyperintensity in the hippocampus. There's also what appears to be hippocampal atrophy here. And there is in D shown that there's also sinusitis present. An LP was performed. He had an elevated opening pressure. He had a slight pleocytosis of 12, and HSV1 and VZV were not detected in CSF. However, SARS-CoV-2 virus was detected in CSF in this case. And interestingly, in this patient, it was not detected in the nasopharyngeal swab. So he did have a systemic illness, including respiratory compromise, that looks like COVID-19. We do believe this is COVID-19 just based on reviewing the case carefully. But it's interesting to see that he had this presentation. Now, again, this is interpreted as meningoencephalitis due to COVID-19. The neck stiffness, I think, does suggest that. Some of this suggests that, but I think the question that you could ask is a seizure that was unmasked in somebody with hippocampal atrophy causing these MRI changes, and maybe the patient had entry of the virus into his nervous system with some inflammation, but not necessarily an overall encephalitis caused by COVID. So I just think that as neurologists, we have to keep in mind exactly what's going on and that this is a pretty limited presentation. So I'm continuing to talk, but if people have questions, again, they can ask. This is a patient that was seen here at Yale and has been reported in a case report that is written up by Shelley Farhadian, who's, again, a joint neurology and ID faculty here at Yale. So this is a patient that was on the Donaldson service who presented originally to the hospital with seizure, so not known to have COVID-19. She's a 78-year-old woman, had had a remote renal transplant and was on tacrolimus. She presented with a witness seizure at home, and the family said she'd had confusion for a couple of days before that. She was admitted with altered mental status. Her tacrolimus level was low, subtherapeutic, and you guys probably know that one of the toxicities of tacrolimus can be seizure. But in this case, it was low. She had an EEG that didn't show anything localizing, just mild generalized slowing, and her MRI showed patchy white matter hyperintensities, which are shown here on the right. This is her flare. And this is non-specific. It was read by radiology as being ischemic white matter changes. Hospital day 4, she developed a fever and a cough, and then she had a nasopharyngeal swab that showed that she had SARS-CoV-2. So she was somebody who actually had COVID-19, but her first presentation was seizure. She had an LP, and again, I think it was before her the COVID-19 diagnosis. Opening pressure wasn't done. She had only 2 white cells, protein and glucose were normal. HSV1 and VZV PCR were not detected. Dr. Farhadian was able to consent this patient's family to a research study that allowed for research testing of the SARS-CoV-2 virus in the CSF. Again, based on research testing, and this was testing after the sample had been in the fridge for a week, the virus was not detected, and several different methods were used: PCR, metagenomics, and culture. But interestingly, in this one individual, when we compared some inflammatory biomarkers shown in orange from this individual to controls that we've collected for another study who don't have any other kinds of infectious illnesses, inflammatory markers were much higher in the CSF in these individuals as well as in blood. And one of the inflammatory markers in particular, which is MCP1, was much higher only in CSF, not in blood. Again, this is N of 1. But it is interesting to wonder whether there is localized CNS inflammation, and that may have been contributing to seizures in this context. So again, and there's another report also of seizures in a patient in an Iranian case, and that is cited here. Again, I invite people to read those cases carefully. Shelley's is probably going to be posted on bioRxiv, I think, soon for people to look at with more detail. So one of the other manifestations that was mentioned in the Wu et al. Article, which was the review of 214 people, was increased rates of cerebrovascular disease in people with COVID-19. I'm used to saying HIV. Again, I think this has to be really, really carefully evaluated. It's interesting to think about why people might be having increased cases of cerebrovascular disease or cardiovascular disease related to COVID-19, but I think really the jury is still out whether or not this is specific at all to this illness or whether this is simply rates of diseases that we would be seeing anyway in acutely ill hospitalized patients with other risk factors. I will say that SARS, the original SARS, did have cases of cerebral infarction and stroke associated with them, and I think that was something that was reported, although not widely reported, associated with that condition. Remember, there were only about 8,000 cases of SARS worldwide, so none of this happened that frequently in that disorder. However, we have, the 2 million people probably living already with COVID-19 right now worldwide, that the concern is that these things will be much more frequent. We do know that in SARS-CoV-2, there is coagulopathies, which I mentioned earlier when we look at just lab values for people with hospitalized illness. There's also thrombocytopenia and a prothrombotic state. So elevation of D-dimers is something that's been clearly seen and is followed actually to clinically examine these patients. We also know that there are ACE2 receptors on the endothelial cells and the pericytes lining the blood vessels. So it brings up the question of whether or not there's actually some direct infection of these cells, and this could be leading to vascular inflammation. So I think there are lots of questions. I know Lauren Sansing is very interested in this question, and Kevin Chef as well. And I think that hopefully we're going to see some emerging studies on whether or not there are really systematically collected data that tell us about rates of stroke in people with coronavirus COVID-19. This is a paper that, again, is a preprint, not peer-reviewed. The images aren't great, and the paper, I think, it has to be read carefully to think about exactly the methods, but it's suggestive, and again, it's something out there in the literature that people will look at and think about. This was looking at 225 patients who were hospitalized with COVID-19 in Wuhan, and showing that 13% of them had cerebrovascular disease. So 11 people had ischemic stroke, one had a venous sinus thrombosis, and one had a cerebral hemorrhage. And imaging from these individuals, which is shown here, on the left are the brain CTs, on the right are the chest CTs. I don't know why they look like they're the same shape as the brains. And then there's a venogram for the individual with the venous sinus thrombosis here in the right. And in this paper, again, this is a retrospective study. It's very descriptive. It's simply trying to show it's almost like a case series. Show that people with cerebrovascular disease were older, had multiple risk factors, hypertension and diabetes, more severe disease status, meaning more severe coronavirus disease, higher inflammatory responses such as CRP, and higher D-dimer and lower lymphocyte count. So again, the more severe illness, more risk factors. These are these people who would be having these kinds of cerebrovascular events in any kind of situation with acute severe disease, or is this somehow related specifically to this virus and what it's doing, either in terms of thrombosis or in terms of vascular effects? Okay. Now I'm going to mention a couple of things that I think are much more common and I think are much less well understood even than these more overt neurologic conditions. So one is headache, and I think that many reports from China, there are many good reports now, and you can see references here from the Lancet, British Medical Journal, Journal of Clinical Medicine, that are large studies looking at thousands of people and showing fairly significant rates of headache. And even for some people, it's a presenting symptom. So we've talked at one point about what the screening procedure should be for healthcare workers for COVID-19 testing, and I think at some point headache made it onto the list. And in fact, now, looking at the data, it does seem to me that there have been individuals where headache was the first symptom that they presented with in their COVID-19 illness. The experience of clinicians at the hospital that I've spoken with, a lot of people have said, oh yeah, I've talked to a lot of the patients have bad headache. Nobody's really worked that up or evaluated it more or systematically, but it does seem like something that's being commented on. I think the real question is headache and COVID-19 different than any other acute viral illness? So we know that a lot of people with illnesses, like viral illnesses, flu, colds, mono, have a headache. And generally, it's usually thought to be a sort of non-specific cytokine-driven condition. We haven't systematically done research studies that do lumbar punctures, for example, in people with these illnesses, and it's something that Shelley Farhadian has been interested in proposing. But these are in things like influenza conditions. I don't think it's well understood what causes headache, but we think it's non-specific. However, there are viruses that have neurotropism, where headache is part of an invasion of the nervous system. So acute HIV, which is what I spend all my time in Thailand studying when I'm there, is a condition where the virus actually enters the CNS very, very early. So within 8 days of infection or so, when people first get HIV, you can detect HIV in the spinal fluid, as well as a lot of inflammation in the brain based on spinal fluid and imaging. And headache is a very big component of that acute retroviral syndrome that a lot of people experience. And we know that that actually reflects a meningitis and encephalitis that's mild, but actually manifests during that period. So I think the question of headache in COVID-19 is this just general headache associated with systemic cytokine storm or cytokine abnormality? Is this actually due to direct inflammation in the CSF? And I think the data from the one single case that we have of the seizure patient from Yale who had inflammatory biomarkers elevated in CSF despite no white count is a little bit interesting, although again, it's a case of one and it was a research sample. Number two, is there actually virus in the CSF that's causing headache? And then I think there could be vascular effects. Could we have vascular inflammation? And could we even have elevated intracranial pressure? We don't know whether or not the case that had the mental status changes, had a high ICP, is that something that's happening more frequently with headache? And I think all of those are questions we just don't know the answer to. There's been a lot of attention, particularly in the lay press. There was a lot of kind of, I can't find a single actual research paper on loss of smell or taste in COVID-19, but there's a lot of press articles, which is something that a lot of people are saying. A loss of smell and or taste is a frequent symptom, and in some people it's a presenting symptom. And even in some people who seem to be otherwise asymptomatic, it may be a symptom. I have a dear friend who is an infectious disease doctor in Italy who was hospitalized for 3 weeks with COVID-19. And after she was discharged, this was over a month ago, before I had heard in the press about the smell and taste loss, she said to me something funny: although it's likely not neurologic, it's a complete loss of taste that I myself have realized after a while, with her lovely Italian, a translation of writing. But I think this is something very, very common, and I think it's real. I think what we don't know is what this is due to, and it has been interpreted as a neurologic finding. For example, in the Wu paper, loss of taste and smell is considered neurologic, but I think we don't know whether that's true or whether or not it could be disruption of the olfactory epithelium. I think some of the arguments that it might actually relate to something going on in the neurons is that for some people, it seems prior to any respiratory symptoms. So it suggests it's not just due to sort of nasal congestion or nasal inflammation. The other thing that's interesting is that compared to flu, there are fewer upper respiratory tract signs in COVID-19. So rather than having a really runny nose and sneezing being a big part of COVID-19, it's often shortness of breath, tightness of your chest, cough, rather than respiratory symptoms, which may suggest that it's not just respiratory nasal inflammation. So in terms of understanding this one, I think one question is loss of taste separate from loss of smell? Probably not. It probably is all the same. But if there is independent loss of taste, maybe we have to look at other cranial nerve involvement as well. I think another question is, is the virus actually infecting the olfactory neurons, or is it just infecting the olfactory epithelium and causing disruption? And the other question, which is kind of, I would say, interesting, but really just we just have no data, is that if there's loss of smell, could that potentially represent neuroinvasion into the neuron, into the olfactory nerve, or even potentially through the cribriform plate into the olfactory bulb of the virus? And here is actually one reference, which is in preprint. This Brown paper is kind of interesting, that they did sequencing of lots of different cell types from the nasal epithelium and the olfactory neurons, and they only found presence of the ACE2 receptor in the epithelium. So their conclusion is that this must be only from the epithelium. But I think, again, that's not peer-reviewed, and we need more data. So there's a couple of other reports. I mean, I think one of the things that we all wonder is, when there's such a prevalence of thousands, millions of people worldwide getting an acute, severe viral illness, are there going to be a lot of immune-mediated neurologic presentations? And there's a couple of reported in literature, and I have heard incidentally from others personally that people have experienced some interesting or concerning immune-mediated neurologic types of symptoms or signs. There's one very, very dramatic fulminant case reported in literature. This is of acute necrotizing encephalopathy. It's a woman, this is reported in the US, a flight attendant who, I don't remember where she had traveled, but she developed cough, fever, and then altered mental status. And she was SARS-CoV-2 positive in a nasopharyngeal swab. Her mental status was worked up extensively, and she had an MRI brain, which was very, very abnormal, as you guys can see. So there's abnormalities in bilateral thalami, medial temporal lobes, and the subinsular regions. And these are not only bright on flare, T2 hyperintense on flare, but they show likely some hemorrhage, and they also are ring enhancing. And this is interpreted as acute necrotizing encephalopathy. The CSF, unfortunately, was really contaminated with blood, so they didn't have a good cell count, but they did show that there was no HSV1, VZV, or West Nile virus. They did not test for SARS-CoV-2 in the CSF. This is presumably, and it's interpreted as an immune-mediated phenomenon, given that it's a condition that is otherwise described after other acute viral illnesses, mostly in children. And there have been two other case reports of what we think of as immune-mediated neurologic diseases. Interestingly, we usually think of these as post-infectious neurologic diseases, where typically people have infectious symptoms and then later they present with these, but in fact, in both of these cases, these were much earlier. So there's a case of Guillain-Barré that's being reported, and this is from China, that had a woman with acute weakness in all four limbs, which progressed over a single day. She also developed areflexia and some sensory changes. She had a normal white blood cell count in CSF, but her protein was elevated, and her nerve conduction study showed demyelinated neuropathy. It wasn't until day 8 of this presentation that she presented with fever. And then she was found to have brown glass opacities in her lungs, and she was tested, and she had positive SARS-CoV-2 in her oropharynx. So this again would suggest that maybe this is associated, but is it actually from this condition? Is it possible she got SARS-CoV-2 after she developed Guillain-Barré in the hospital, for example? Nosocomial infection, it's not known. But I think it's interesting, and this was actually presented very, I would say, fairly in Lancet Neurology, where they really said, is this coincidence or is it related? But it does suggest there's a potential relation. And then there's an acute flaccid myelitis case that is in preprint available from China. I have the citation here. This is a little bit less clear, this case, because not very many studies were done, but it's a gentleman who presented with paralysis of his lower extremities and bowel and bladder incontinence 6 days after his initial fever and fatigue started, and then he also was positive for SARS-CoV-2. So this gentleman went on to develop respiratory difficulties and compromise consistent with generalized COVID-19 infection, but interestingly, his paralysis started prior to the other symptoms. However, there's no imaging or CSF available in this individual, so it's a little bit limited how to interpret the case. So I'm going to end on talking about what some of the efforts that are ongoing at Yale to study some of the neuro complications or potential manifestations of COVID, and also hopefully, importantly, to help take care of our patients better. So some of you know that there's been this neuro-COVID consult service that has been started. This is, I think, a work in progress. We're still trying to figure out how to be most useful. But this is a secondary consult service that is basically a service to the primary neurological consult service to provide any additional COVID-19 related insight. So right now it's being run with a single resident. It's either Lindsay or Tova. I've been attending. We have Zoom rounds at 2 o'clock on weekdays. And I'd say that anybody's welcome to join our Zoom rounds if they're interested, and I can send you a link. We really often only had one consult per day. There are multiple patients with COVID on the neurology service, but the team is asking us about patients where they think that additional input that may be somehow COVID specific would be helpful. I think that's a difficult thing to try to figure out, both for the team and then to see where we can actually contribute. But hopefully this is going to be a way for us to keep track of all the neuro consults, which we are tracking in sort of a ongoing document to maybe learn more about these patients. We'll certainly learn more about COVID-19 as a disease and potentially provide some service to the patients and the teams. I just want to credit the terrific team of residents and faculty who wrote this fantastic review article over a period of a couple of days to try to pull together the literature that I just showed you, again, with hopefully caveats of how limited the information is to date, but raising some of the questions. Adil drafted this paper, and Lindsay made figures and also made a lot of important contributions. Tova, Shelley, and Dina also really contributed to make it, I think, a strong article that not only includes these reviews, but also some recommendations for evaluation and for treatment. There is a study that has been put together by a team of investigators across schools at Yale that is a biorepository study. It's collecting all sorts of different specimens, nasopharyngeal specimens, pulmonary specimens, stool, rectal, etc., blood. And Shelley Farhadian, who's our faculty member also in ID, has been instrumental in directing the neurologic part of the study. I've helped her with the clinical neurologic evaluations, but she's really been the person to help move this forward. Last time I spoke with her, they had consented 88 people and had collected specimens from 88 people already at Yale, but I think those numbers are probably much higher because that was last week. And part of that study includes systematic screening. So there's a series of specific neurologic questions and asking about certain kinds of symptoms for every single individual who's enrolled. That's being done by some dedicated students. And also, Shelley has been able to manage collection of CSF. So all the cases who have a clinical indication for LP, and 2 have been collected so far, and there are also going to be a limited number of research-only LPs. And I'll also mention that Jen Kim and others have brought, I think, a really important multi-site study to Yale, which is run by, it's directed, I think, by Sherry Chow, who's at University of Pittsburgh. It's run by a team of neuro-ICU attendings, I think women neuro-ICU attendings, throughout the United States, and it's looking at neuro-ICU outcomes. So for people who are admitted to the neuro-ICU with COVID, and also people who do not have COVID, to see whether or not in the era of COVID, there are different outcomes for neuro-ICU patients, which is really important. And a couple of planned studies. One is Kevin Sheff and I are trying to work on a study to use a portable MRI scanner in these individuals because there are so many limitations on transporting people to the main MRI and personnel issues and contagion and infection control issues there. And then Shelley Farhadian, again, is planning a long-term study to see whether or not there are any follow-up sequelae in these individuals. So the last 2 slides are to, one, provide some resources. And I think Jeremy said this is going to be recorded. So I thought this might be helpful for people. The top two resources are absolutely terrific, really, really worth watching. There was a Dean's workshop held a couple of weeks ago here, state-of-the-art talks about all aspects of COVID-19, clinical public health, infection control, testing, pathogenesis, immunology, absolutely terrific. And the second is an earlier set of presentations that's at actually at an HIV conference that included people from the CDC in China, Tony Fauci, a really fantastic coronavirus virologist, all talking about this virus. And I also list here some of the guidelines that have been introduced by some of the working groups of neurologic providers and putting together guidelines for care of patients with neurologic conditions in the area of COVID. And I would say that the myasthenia guideline was importantly contributed to by Richard Nowak. And I think that that's really exciting that we have people at Yale who are on the forefront of doing this. So I'm going to end. I know I'm at the end of the hour. I didn't allow a lot of time for questions, but I can stay on for a few minutes. I think a really important point here, and this is a quote directly from the Mao paper, which is the one that described the high rate, over 30% of neurologic manifestations in people with COVID. So this is basically saying we can't distinguish whether these are from the virus or whether from the pulmonary disease and multi-organ systemic injury that people have who are so ill. And so I think it raises these questions. Does mental status change or seizure in a COVID positive patient? Is it just toxic metabolic encephalopathy, or is there something COVID specific? Number two, will post or peri-infectious neurologic immune-mediated disorders be as more frequent or just as frequent as other acute infections? If they are, I think we're going to unfortunately be having to deal with a lot of these in the coming weeks because there are so many patients with these conditions in our hospitals in the US. Are any of these disorders, such as vascular disorders, encephalitis, seizure, are they related to SARS-CoV-2 infection of cells, or are they bystander effects, or are they somehow immune-mediated events? And then a final question, which I didn't really get to, but I think is another concern, is whether there'll be long-term consequences of COVID-19 for the brain. And we know that ARDS, there are a lot of post-ARDS complications for people. There are critical illness complications for people. And of course, after there was post-encephalitic Parkinson syndromes are related to Spanish flu. So I think some of these long-term outcomes are also real questions.